Some issues about competing risk, balancing benefits and harms. Again, I'll refer to some work that was presented earlier today, namely the issues of targeting lower versus higher arterial oxygen saturations in preterm infants. Of course, this information comes from the brilliant collaboration around the NEOPROM trials, and in many ways represents some of the best trial data we have at hand, and yet leaves us all still quite confused about what the right choice might be. These 5 trials that were done worldwide enrolled just shy of 5,000 infants. They were prospectively planned to have an individual patient data meta-analysis, but I'll be presenting the study level analysis as they don't differ greatly. First, there was no difference in the primary outcome of combined survival or major disability at 18 to 24 months. Second, there was a concerning increase in the risk of death in the infants who received lower targeting. Severe retinopathy went in the opposite direction. There was a decreased risk of severe retinopathy with infants in the lower target. And necrotizing enterocolitis was also improved in the infants who received higher oxygen saturation targets. This is difficult. You have serious outcomes in either arm that are not consistent and leave us with difficult decisions. One could argue that, in fact, the primary outcome, death or major disability, was no different, and therefore the results say that both are adequate, but I don't think the community has interpreted the data that way. It has taken more the approach that there's a trade-off between benefits and harms that you need to look at in your own practice. Quote from a commentary from Barb Schmidt spoke about the fact that these trade-offs are probably not the same for each of us, and that we might actually practice evidence-based medicine and come up with some very different suggestions about what we might want to do in our individual nurseries. If you make the argument that the primary outcome was no different, death or major disability, then the answer is do what makes sense or keep doing what you were doing. If, on the other hand, death is overrepresented in your population, you would err towards the higher saturation goals, versus if retinopathy was more of a problem, where you might choose lower goals. And so knowing the evidence is one thing, but knowing your practice and your concerns is another, and you might well set up different policies and procedures and incorporate the evidence differently depending on your perception of your unit. Let's move on to the issue of values, because even when you have the evidence and know the evidence, people will make different decisions based on what they value. Here I'm going to look at the trials of prophylactic indomethacin, reflected by the meta-analysis of Fowley and colleagues, but remembering that, in fact, the meta-analysis is dominated by the large, methodologically important and sound trial of Barb Schmidt, the TIP trial. First, the problem is still there. Severe hemorrhage has changed little over the past decade, and it still remains at around 10 or 11% of our population of very low birth weight infants. Prophylactic indomethacin, and certainly many of the trials in the meta-analysis, were first focused on whether or not you can close the patent ductus. And the fact is it does a brilliant job in decreasing signs of adductus as well as symptomatic ductus, and decreases the perceived need for PDA ligation. There is also a measurable and meaningful decrease in severe IVH, an outcome that most of us, on the face of it, would argue is very important. And there is no increase in problems such as periventricular leukomalacia, so no obvious increase in ischemic disease. That said, when the TIP trial in particular followed up the infants from this trial, there was no translation downstream of the benefits in terms of brain hemorrhage and developmental follow-up. And here we have pretty precise estimates that there is no profound impact on these events. So then it becomes a question of what you value. And certainly I don't think anyone in the audience would say, oh, I need to give prophylactic indomethacin because I want to decrease the sound of a murmur. But PDA ligation, well, that's pretty practice-specific and not necessarily required. But when you get to severe IVH, you start to get some people's attention. Some argue that if that doesn't translate further upstream to improved development, then it's not meaningful. It's just a cost with some risks. Others might argue that that is a meaningful outcome, that the lack of needing ligation is a meaningful outcome, and choose to use prophylactic indomethacin. And so values, looking at the same evidence base, can be argued either way as being half full or half empty. The fact of the matter is we're not seeing an increase in the use of indomethacin. Clearly, after the TIP trial, most people, I think, felt that since it didn't improve development, it wasn't worth taking the risk of giving it. I'll briefly make two more points. I don't mean to go too fast for the sake of time. Talk a little bit about false precision and false optimism, and look at the issue of nitric oxide. Here you have a therapy that is so fantastic when we look at the basic science and understanding the basic science, is very meaningful in the improvement that we see in term babies' outcomes, and yet has very limited outcomes of improvement in the preterm infants. We have both study-level and patient-level meta-analysis on this. In Keith Barrington's analysis done with Neil Feiner, we don't see any meaningful improvements in any approach to using INO in preterm infants. In the individual patient data meta-analysis, the same is true. Very few important impacts emerge. Clinical reports from the NICHD, from the NIH, from the AAP, all suggest that we shouldn't be using it. And yet, when Pediatrics looks at its database, we see a large increase in the use of INO in preterm infants, particularly the infants 23 to 29 weeks. So much so that almost half of all the INO used is being used in this non-indicated population. In other work through pediatrics, we see that, in fact, when they look at infants in centers who receive INO and those that did not, that, in fact, there was no impact on mortality, and yet it keeps being used. And I'll sum up with this other issue, which reflects the issue of generalizability. Trials are done with specific interventions in specific populations. Many of the trials that we rely on for our practice are actually information that was gleaned in the 1980s and 1990s, and therefore is very limited from many issues about co-therapy, gestational ages that are being resuscitated. And so even a therapy as common and well accepted as antenatal corticosteroids probably needs further thought about how we are using it and what the policies and procedures are at our centers. I'll just touch on the meta-analysis, you all know it, but a huge number of studies, 30 studies, over 7,000 infants, and obviously the results on decreasing RDS and decreasing neonatal death. Strong statements from knowledgeable guideline partners regarding use. But the question remains, now that we're resuscitating the 22 and 23 weeker, these infants were never studied in the original trials. And it is unclear whether or not, as a matter of practice, we have accepted guidelines that allows for exposure of antenatal corticosteroids. In our own work looking at this in the Vermont-Oxford Network, we recently published in JAMA, suggests that in fact, for those infants where postnatal life support was offered, a significant number still don't receive antenatal corticosteroids. So here we've got 3,800 babies who people decided, yes, we should resuscitate these tiny babies, but in fact, no, we're not going to give antenatal steroids. 50% or so of the babies 22 weeks did not receive antenatal steroids. And yet, when we look at these populations, infants given postnatal life support, so the decision has been made to try to optimize outcome, we see that there's a twofold improvement in survival if these infants received antenatal steroids, and in fact, a more than fourfold improvement in survival without major morbidity, suggesting that in this case, we need to consider extending the evidence in our practice and make that speculative jump towards greater therapy. And so I'll end at this point and just open up to questions about why there is this difference between evidence and practice, what is justifiable, or any other thoughts you have on the subject. Thank you.